One of the considerations I have in giving a talk, and each of these talks, is we talk about an integrative, holistic approach to GI problems. And I don't have GI problems who I see in my clinic. So how do I begin to consider that? And what I'll do is I'll first take you on a journey through a bigger picture of how to consider looking at what's going on with a person in relationship to this function of their gut, this function of assimilation and digestion that I spoke of yesterday. And at the end, I hope, we'll see how time goes. I'll go into the specifics. We'll glaze over those pretty quickly because you'll have them as a text source for yourself in the future. But I want to start with this quote from Ayurveda, again, from the Sushruta Samhita. A person's basic emotional and physical tendencies are in balance, whose digestive power is balanced, whose bodily tissues' elimination functions and activities are in balance, and whose mind, senses, and soul are filled with vitality. That person is said to be healthy. Now here we see from the oldest medical text that we have, the emphasis is on digestive power, Agni, to break down the food, and the elimination function that's going on. So as Dr. Pizzorno talked about yesterday, death begins in the colon. Let's focus on what our interface is with our environment, and I'm going to take you through a consideration of talking about what I mentioned briefly yesterday, Digin. We're going to look at digestion and how we assimilate things from our environment. We're going to look at intestinal permeability and how the structure is to allow for the discernment, the separation of the two-sorter in Chinese medicine, of the wheat from the chaff, of tolerance versus intolerance. We're going to look at that microbiome inside us that is involved in the metabolism of the food that we take in. We're going to look at the role of fire and inflammation and how 70% of the immune system sits in the lining of the gastrointestinal tract, and we're going to talk about gut feelings. That is, this relationship between our gut and our brain that happens over and over again. I'll use this construct of looking at, well, what's the root cause? Now, if you look closely, these are the same 5 things that I talked about yesterday. Is there infection? Are there dietary insufficiencies and excesses? Are there allergens and sensitivities? Are there toxins or stressors that are going on? So we look to the GI tract as this sort of fundamental or integral node in the process of our relationship to health and healing. And when we do that, we first evaluate what's going on with Digin below the slide there. We consider what's happening in each of these arenas. And we do that, then we treat the underlying cause. Where is it if there's insufficient digestion or insufficient nutrient intake or excesses, we balance that out. And we'll talk about pancreatic insufficiency and how to check for that, and the role of PPIs, and we'll look at dysbiosis, imbalances in the gut flora. It's not so much that we're looking for pathogens, we're looking for the way in which the forest is not growing in a healthy and diverse way, where the gut flora is not growing in a healthy and diverse way. And while I won't be emphasizing this in the talk today, I have to add that fundamentally the diversity in our gut is a direct reflection of the diversity in our diet, the diversity of the phytonutrients in our diet. And we'll look at the role of the foods that we take and how they may be pro-inflammatory or anti-inflammatory. So we come back to this Digin consideration, and we start with digestion. Because in our lifetime, we eat between 30 to 40 tons of macronutrients and micronutrients. Now, if we're eating those, but we're not digesting them, or we're not absorbing them effectively, all of the substrates for every protein and enzyme in our body Every cellular structure is going to be altered. And if we eat things that include toxins, they're going to stick around and have an effect on the metabolic process. So one could say you are what you eat, or you are what you don't shit. But the fact is that, if we have to look at what it is that we're taking in as intake and how does that effectively work. Now, when we look at data from the National Health and Nutrition Evaluation Survey, as reported here by Lauren Cordain, just the foods that we're eating in our diets, we're not even meeting the daily recommended intakes that should be there. We're deficient in zinc, in calcium, and magnesium, and B6. So even if we eat a good diet, we're actually not getting all that we need. And then we have the process of digestion, of chewing our food. Are the acids in our stomach able to activate trypsinogen and pepsinogen to make them trypsin and pepsin and break down the proteins that they have? Or do those proteins come in and remain undigested and move downstream and feed the bacteria in the terminal small bowel, leading to bacterial overgrowth? Is there proper stimulation of the microvilli, of the disaccharidase enzymes on the microvilli that send a signal of cholecystokinin to the pancreas and the gallbladder and say, hey, we got some food coming in. How about if you release your amylase, lipase, and proteases so we can break it down properly? And what we've seen in studies that I've been involved with in the laboratory, 32% of patients with IBS aren't making sufficient amounts of pancreatic enzymes. It's amazing. And that's going to affect our ability to digest and absorb our foods. It's going to affect other things, as we'll see downstream, because those undigested foods are feeding the bacteria downstream. And we see that these microvilli and the villi in the proximal small bowel may be atrophied, as we see with celiac disease, but we see it's actually more prevalent than that. Now, when we eat food, digestion starts with our thought process, with our consideration of food. If I was to begin to describe this beautiful salmon that had glazed vegetables on it with a little side of couscous and began to elaborate on how succulent and beautiful it was, half of you at least already have some salivary activity going on, right? Okay? So it starts in our mind and what we think. It starts when we go to the grocery store or we go out to our garden and take our food. And we take time to cook and prepare our food. This is part of the digestive process that needs to occur. But when it doesn't occur, we don't prep properly, and our stomach's not ready. Now we can see hypochlorhydria that can happen from eating too quickly. We can see it happening from the aging process. We can see it from taking proton pump inhibitors. An interesting thing about proton pump inhibitors and hypochlorhydria, they say, well, PPIs are meant to be able to reduce the amount of acid that you have in your stomach. Now, if we look at a population over time and we look at the utilization of PPIs as they age, it goes up. But if we look at the production of acid in people who aren't on PPIs over time, it goes down. So how do those two things work together? We'll see later that over half of the people who are on PPIs shouldn't even be on them. They don't have the fundamental underlying issues that cause the problems. And when we take these agents, they actually decrease the ability of digestion to occur properly. And then the food goes downstream and starts feeding the bacteria. And when there's an overgrowth in a biofilm layer and it prevents the absorption of B12 and other nutrients, we have problems that go on. So this idea of small intestinal bowel overgrowth, that's a consequence of hypochlorhydria, whether it's from the aging process, from chronic disease, or from the presence of PPIs, it leads to chronic long-term problems, including B12 deficiency and mineral deficiency. Hypochlorhydria. And we can use tools of a betaine hydrochloride challenge test, or using a Heidelberg radiofrequency test to see is there adequate acid going on in the stomach, or we can give trials to support that. And then there's the pancreas. I've already mentioned that the stimulation of the pancreas comes from the proximal small intestine. And if we're not producing adequate amounts of pancreatic enzymes, we're going to have problems with digestion occurring. And I'm telling you that from looking at stool tests, which I've had the great good fortune of doing for the last 15 years, more stool than you could imagine, we see this very, very commonly. So this idea of pancreatic insufficiency will occur when our patients have some bloating after eating. They may have some loose or watery stools. They may have GERD kinds of symptoms that go on. These are common symptoms that we see when there's pancreatic insufficiency. So that's the digestive piece. And then there's the absorption. When we look at the surface area of the small intestine, it's as big as a doubles tennis court. It's a single cell layer thick. The job here is we have to absorb the nutrients that we take in, but we have to make sure that we don't take in the toxins and the larger molecules and the pathogenic bacteria that are present there. How does that work? I mentioned the two sorter in Chinese medicine. The sorter, it separates the wheat from the chaff. It's also involved in the development in the small intestine of sorting out what's me and what's not me. We'll talk in a few moments about oral tolerance and recognition of what's supposed to be there and what's not supposed to be there, and developing reactivity to that. So when we have permeability or leakiness in this membrane, we can have problems. Leakiness that can be caused by inflammatory changes that go on and thinning of the biofilm layer that's there to protect. We can see it from not having adequate bile production. We can see it from celiac disease. We'll talk just briefly about celiac disease. 1% of the U.S. population has celiac disease. Now, the data from the Mayo Clinic shows that in 1973, when they used the testing of a tissue transglutaminase, they found that 1 in 400 of those samples had a positive TTG, which is not exactly the same as celiac disease, but it's got a 97% sensitivity. When they measured their blood supply 15 years later from 1988, they found that 1 in 200, 0.5%, had positive TTG. When they measured it again in 2003, they found that 1% of the population, 1 in 100. We had a 15-year doubling time of celiac disease. Pretty amazing. What's going on there? We need to be looking for it. The data tells us that 90% of the patients, of the people in the United States who have celiac disease, are unaware of it. And in addition to celiac disease, there's a non-celiac gluten sensitivity that is also present. In what current estimates from my GI colleagues are, between 10 and 20% of our population has a non-celiac gluten sensitivity that's going on. Now, there's great serologic tests to look at this, but I'm talking about it here because celiac disease has an impact on the ability to absorb, where there's villus atrophy, and it also has an effect on the increase in permeability issues that are present there. So when we look at this idea of structure and barrier and intestinal permeability, we begin to see that the large molecules that are in our gut should not be absorbed, and the small molecules should be absorbed. There's ways to test this using a double sugar test, as we see below with lactulose and mannitol. There's other ways to be able to look at permeability using a particular test called zonulin. Now we see on the right where the large molecules are actually able to move through because there's permeability. Increases in zonulin open up that space and allow these larger undigested food particle molecules as well as bacteria to move in and to stimulate the immune system, which sits right below this single cell layer. And we also see that when there's rattiness or changes in the lining, that absorption doesn't occur properly. So we can spring a leak. Now, Dr. Alessio Fasano, who has written extensively on celiac disease as a model of autoimmune disease, tells us and shares with us that with issues of intestinal permeability, it's one of the hallmarks of autoimmune disease. That we've got to deal with what's going on with that permeability issue. So here we see antigens. Let's see if I can do this. Oh, can't. Antigens coming in right here. So antigens are going to stimulate an immune response where we see neutrophils, which contain something called calprotectin, which is a zinc binding protein, but it's a marker of inflammation increase. Then we see inflammation and reactive oxygen species that we've heard about. The body releases glutathione to try to take care of that. There's damage that occurs, and there's more permeability. So we just see this snowballing effect that goes on. So what causes that? Well, interestingly enough, while inflammation can cause it, we can also see that chronic strenuous exercise can cause that. We see this as a significant issue in, for example, marathon runners, especially during the last 6 miles of their races. We see that increasing age and nutritional depletion can cause it, but we also find that stress can cause it. Dysbiosis and alterations in the gut flora, as well as food allergies and sensitivities. So when we have changes in permeability that go on, it stimulates the immune system, and there's an overall increase in the antigenic burden that goes on. But we can do something about it. So the data shows us that various agents, including L-glutamine down at the end there, L-glutamine, which has been studied in ICU settings, is the principal fuel source for the cells that line the small intestine, the enterocytes. They don't use glucose to repair and to feed themselves. They use the amino acid L-glutamine. We can use that as an agent. We can use probiotics. We can use quercetin, the anti-inflammatory, to help heal the permeability issues that are going on in the gut. As I mentioned, some of the work from D'Souza and from Doug Whitmore out of Harvard and at Indiana University have shown, even in patients who have multisystem failure, who are in sepsis, giving them L-glutamine decreases their time in the ICU and decreases their mortality rates. So ways to help deal with the permeability issues that go on. In another study here looking at rat pups, we found that by giving them omega-3 fats, by giving them prebiotics, fructooligosaccharides, and lactobacillus, helped to decrease permeability, intestinal permeability that went on. Now there are further studies that have been done looking at food allergies and food sensitivities, and we want to differentiate IgE-mediated food allergies from food sensitivities that can be immunologically mediated, IgG for example, and considering these in the process is one way to look at what's going on with my patient. Now here's a classic study from Atkinson that was in Gut in 2004, where they took 150 people and they did IgG testing on them for food sensitivity, and they said, well, let's take 75 of those people and put them on a diet that is consistent with, that removes the foods that they're sensitive to, and the other 75, let's go ahead and give them the foods that they are sensitive to, continue to give that to them. And what they found was that there was a 26% decline in symptoms and in quality of life. And when they did the crossover portion of the trial, where they took the first 75 and they gave them the foods that they were sensitive to, their IBS symptoms came back. And when they took the second cohort and they gave them, or they removed the foods that they were sensitive to, their IBS symptoms and their quality of went down and their quality of life improved. So that's one way of doing it, and another way is to do an elimination diet, which I talked about briefly yesterday. Now, the two biggest actors in our diet are gluten and milk, gluten and dairy products. Here's the top 10. So when we work with an elimination diet, we work on eliminating these 10 foods initially for a 2 to 3 week period of time, and then adding them back one at a time. You give them, after 3 weeks, you start back and you give them gluten and you see, okay, do you have a reaction to gluten over the next 48 hours? Get a good dose. Don't take a little nibble of it, but get a good dose of it and say, do I notice some GI symptoms? Do I notice some migraine symptoms? Do I notice a backache? Do I notice bad dreams? Do I notice that my boss tends to be particularly acerbic today? Any of those kinds of things. So we're looking at emotional reactions as well. If we're not sure, we go off it for another day and then we try it again and see if we get a reaction that goes on. These are sensitivities. These aren't allergies, But working with patients to help decrease these sensitivities is a very, very useful tool. And they'll be off of these foods for a 3 to 6 month period of time, and then they'll re-challenge with them and see how they do. Now, we can do testing. We can do like IgG testing, but it's not validated. We can do IgE testing, which is looking for allergy, which is frankly much more common than the peer-reviewed literature seems to indicate. There are low levels of IgE-mediated reactivity that goes on commonly for a large number of people. In studies we've looked at, it's 18% of the adult population will have some degree of IgE reactivity. That's allergy, not sensitivity. It's important to differentiate those two as we talk to our allergy and immunology colleagues, because food sensitivity is a real issue, and it's not an allergy. So now let's go on and talk about my favorite topic, the gut microbiome. On my website at Family to Family, I've got a wonderful little interview that I did talking about the relationship between the gut microbiome, this morning's conversation, and shamanism, this evening's conversation, of seeing, what is the relationship. But the relationship is that what's going on inside of us is related to what's going on outside of us in our world and how we connect to that. Inside of us, we've got 100 trillion bacteria. Now, there's only 10 trillion cells in our body. And if we take the 150 or so species that are in each of us, and in a room this size, there's not one single bacterial species that is in every one of us. That's kind of amazing. So we're really diverse in what we have inside of us. And yet if we take all those bacteria inside of us and we look at their DNA and we compare it to our DNA, there's 100 times as much genetic material. So there's a lot going on here with our gut microflora. We see that the metabolism, yesterday Dr. Pizzorno was talking about phase 1 and phase 2 detoxification and what's going on there. And yet there's more detoxification activity that's happening by these bacteria metabolically than there is in our entire liver. So we have this whole hidden organ that's going on with 100 trillion bacteria, and the gut is the home to 70% of our immune system. Our immune system actually learns how to do its job from the bacteria that start to grow in our gut. And the bacteria that start to grow in our gut, it's sterile when we're born. Our gut is sterile. The bacteria that start to grow are based upon, what do you think? What we eat. But not just what we eat. It matters if we were born by a C-section or a vaginal birth. It matters if we were born by a vaginal birth in a hospital in Africa or in a hospital in Sweden. Studies have been done. It matters if we're breast or bottle fed. It matters if we got intrapartum antibiotics or antibiotics shortly after we're born. And antimicrobial herbs fit in that same category, the berberines, etc. as well. So the environment and everything is shaping what's going on with our gut flora. And that gut flora is involved in educating our immune system. That gut flora is involved in the production of short-chain fatty acids like N-butyrate, which is the principal fuel source for the cells that line the large intestine. So wait, our large intestine doesn't use glucose, it uses the fatty acids, the short-chain fatty acids that are produced by the bacteria that are present. So if we have an imbalance in what's going on, we've got problems. So we started off with this picture, one of my favorite places in the world, Grand Prismatic Pool in Yellowstone National Park, taken from 5,000 feet. This is 100 meters across in each direction. If you look closely, on the right-hand side, you can see the people on the boardwalk there. Why am I showing this picture? This is a picture of the cyanobacteria that radiate different colors that live in different temperatures of that hot pool that's boiling hot in the middle. And as it moves out to the side, it cools. Different thermophilic cyanobacteria radiate different colors. Now, I would say this looks like a heart. And it's a thing of beauty. And when our microbiome, whether it's in nature, in ourselves, is in balance, it's a thing of beauty. And when it's out of balance, we call it dysbiosis. And in this process, we begin to look and say, well, what causes that and what can we do about it? Well, I already told you that the foods that we eat and what we're exposed to and how we're born and how we grow up is going to have an influence on what is the basis, the distribution of our gut bacteria, of our microbiome, that's doing this very important job. It's going to be affected by when we take antibiotics or antimicrobial herbs. It's going to be affected by PPIs. But it's also affected not only by the foods that we eat, but by what we feel. When we're stressed, it changes the distribution of Lactobacillus and Bifidobacter. When we're angry, it increases the amounts of Bacteroides that are present in our system. Absolutely fascinating that these imbalances occur. And when we have dysbiosis, the most common way in which we talk about that now, the two terms are not synonymous, but small bowel bacterial overgrowth or small intestinal bowel overgrowth, SIBO, is a great example of that. When we have foods that are incompletely digested and they move down and they allow the bacteria that are primarily in the large intestine to move up through the ileocecal valve into the terminal portion of the small bowel and actually prevent absorption from occurring properly. We can see megaloblastic anemia because B12 bound to intrinsic factor is sitting in the terminal ileum. It needs to absorb there. Other trace minerals and nutrients are absorbed at that point in time. So if we have this fermentative process that's going on and SIBO is occurring, we have nutritional changes that go on. But beyond that, we see that 78% of the patients from work from Mark Pimentel at Cedars-Sinai who have IBS have small intestinal bowel overgrowth. But much to his surprise, patients with chronic fatigue, with fibromyalgia, with depression, with interstitial cystitis, and restless leg syndrome also had very high rates of small intestinal bowel overgrowth. What's going on there? So when we have this imbalance in our system, we can work to treat it. There's various protocols that have been developed. The one that's been most studied through the PREDICT study with Pimentel and published in the New England Journal uses rifaximin, a non-absorbable antibiotic, a derivative of the old anti-TB drug rifampin. We give it at 550 milligrams 3 times a day for 10 to 14 days. I was talking with a patient yesterday, and she said, well, you know, I've gone on the internet and I've researched this, and it says that most of the people who are treated with rifaximin end up developing symptoms again. And it's absolutely true. There was a poster last spring at the DDW, the GI meetings that I go to each year, and it said, we successfully treated this patient 7 times in a year with rifaximin. I'm thinking, what's wrong with that? And there's this big poster about how it doesn't create drug-resistant sensitivity. If you don't go upstream to look at the cause of why it's happening in the first place and work to correct the issues that are feeding the bacteria that are growing there, you're going to have a problem. But using it as a source treatment and identifying and eradicating that leads to unbelievable symptom reduction in your patients with IBS, and I've used it in patients with fibromyalgia and chronic fatigue as well. We'll hear Dr. Teitelbaum talk more about those issues, and this is just one aspect of it. It's not a panacea, but it's when we have dysbiosis in the system, we need to work with it. Others have used agents, including various kinds of anti-candidal agents and oregano oil and berberines and other kinds of considerations. Don't work quite as well, take a longer time to be able to do. But you've got to address the underlying cause. Why did this happen in the first place? And many times, people will actually be reacting to the simple carbohydrates that are in foods. And those carbohydrates, which they're taking in excess, are going down and feeding the bacteria. So it's not just the proteins, but it can be from carbs as well. So we often will use a restriction of carbohydrates as a dietary intervention when we're treating someone for SIBO or for dysbiosis. So that brings to fore this idea of prebiotics, which are going to be the foods that feed the bacteria, and probiotics, which are bacteria that we have cultivated outside of the environment and given to the person to help bring balance back to the system. A couple things about probiotics before I go forward. One is that, we used to think that probiotics were like grass seed. You could give them and then they would grow and they would seed in the gut and they would continue. They're not. They're tourists. They come through, tourists will have an influence on an economy. They will cause changes that go on there, but they don't stay there forever. And this is true with probiotics as well. The longest that we've seen them last is 13 days within the gut. So I'm going to talk a little bit about the immune system and then come back and talk a little bit more about prebiotics and probiotics. So I mentioned this idea of oral tolerance in the small intestine. We've got to be able to separate the wheat from the chaff. Now we see when there's commensal bacteria that are sitting in the gastrointestinal tract, they're evaluated by the immune system. This cell, this DC cell, this is actually a chiropractor that reaches out with his hands. Why didn't everybody laugh? That was funny. This dendritic cell that reaches out, an antigen-presenting cell, it reaches out and it's sampling and evaluating what's going on in my gut. And it takes that information and it brings it into this T regulatory cell and it says, what do you think about what's going on in our neighborhood right now? And if it's something that the immune system is used to seeing, it says, as my teenage sons would say, it's chill, everything's cool. We're going to release this counter-regulatory or this anti-inflammatory cytokine called interleukin-10, and we're going to be tolerant of what's going on. And the body's doing this 99.999% of the day. But it's also got to be able to figure out when something invasive comes in that has lipopolysaccharides and other things, and the dendritic cell then is saying, hey, I brought this over here and this is not a good thing. I need to release these inflammatory cytokines to mount a localized immune response. I need to use a cell-mediated Th1 response and an antibody-mediated Th2 response, and I need to get things taken care of. So in this inflammatory kind of condition, you can see there can be an abnormal reaction to normal bacteria, or there can be a normal or a hyper reaction to abnormal bacteria. So when we look at something like ulcerative colitis, we can see that prebiotics, that is giving the substrates for the good bacteria to grow, actually can decrease disease activity. They can increase the amount of N-butyrate necessary to help heal the lining of the gut. They can decrease inflammatory markers. The same is true with probiotics, where we use not only Saccharomyces boulardii, an E. coli Nissel, a soil-based probiotic, but also with bifidobacteria in order to be able to help decrease the inflammatory process. I skipped this. I missed a slide here. I'll get to it in a moment. And then we see, in addition to prebiotics and probiotics, this thing that we've been reading about now called fecal microbial transplant, or human probiotic, I don't like that term, transplant. Because when we take patients who have ulcerative colitis, when we take people who have C. difficile that's refractory to treatment, and we've given them probiotics, and in my practice previously I've used Saccharomyces boulardii at doses of 500 to 1,000 milligrams BID. It's useful, but if someone is refractory to those treatments, we've found there's a 95% cure rate if we take the stool that's been extracted from someone else who's healthy, who doesn't have C. diff, and we give it to the donor, or we give it to the recipient. And it can be given by an enema, it can be given by an NG tube. There are a number of papers on this now, and we see a 95% cure rate. And interestingly enough, while I said before probiotics don't last any longer than 13 days, the bacteria that you get from the donor lasts for at least 6 months. We've measured it out 6 months. It lasts at least that long. So there's other things that are going on that we're learning about in relationship to probiotics and prebiotics and their immunomodulatory effect and how they work to help decrease the immune system. But one caveat that I want to add here is that as we look to this particular trial with ulcerative colitis, using a particular form of 8 different types of probiotic, 4 strains of bifidobacter, 3 strains of lactobacillus and strep thermophilus at doses of 3.6 trillion colony-forming units. per day, what they were able to do is they were actually able to induce remission in 80% of the patients with ulcerative colitis. Not just maintain remission, induce remission from an ulcerative colitis flare, which tells me that what's going on with ulcerative colitis has to do with imbalances in the gut flora. And when we work to bring them together, we can decrease the inflammatory process. But that doesn't mean that any probiotic that you get off of the shelf from your local Whole Food store and you give it in super high doses is going to have that effect. We have to think about probiotics the way we would have considered antibiotics from the 40s. You know, if someone came in and they had a staph skin infection and I gave them a gram-negative antibiotic and it didn't work, I would say, antibiotics don't work for infections. Well, it's just the wrong one. We need the right probiotic for the right issue, as we need the right antibiotic for the right issue. 10 years from now, I hope I'm still standing here giving this lecture. I hope they'll invite me back. But I think that we'll have a little Sanford manual, just like we do for antibiotics. This is probiotics and prebiotics, and which things do I use to get which specific effects that go on. So these are the opportunities we have. And then one can say, well, how do you tell? How do you know what's going on? How do you monitor what's going on? If I'm going to use these agents to try to help with inflammatory changes that are going on, how do I evaluate that? And now we have stool-based biomarkers that are FDA approved that can help us to be able to monitor and differentiate between a normal bowel and a bowel that's got Crohn's disease or ulcerative colitis, where these fecal biomarkers are extremely high in inflammatory bowel disease. In irritable bowel syndrome, they're low or normal, although there's a subset of the population with post-infectious IBS who need treatment for the inflammatory component that's going on versus normals. So we've got a whole series of tools that we have in our bag to look at the immune system and inflammation and what's going on, and we've got treatments that can help us out. And then finally, there's the enteric nervous system, where we recognize that there are mast cells and various inflammatory cells that sit in the lining of the gut, and these enterochromaffin cells, when there's an inflammatory response, they send an increased signal back to the brain that says danger, pain. This is where we have the cramping that goes on. So when we have inflammation, we have an increase in the signal going back to the brain. Much of this is modulated through serotonin. 95% of all the serotonin in our body sits in the cells, sits in the gastrointestinal tract. It's amazing to consider. So when we look overall, we can see various kinds of IBS symptoms as relating to serotonergic imbalances. Now we've tried medicines like tegoserod and elestotron to try to bind to both be agonists and antagonists against 5-HT3 and 5-HT4 receptors, and we didn't find them to be effective because they had other side effects that went on. So how do we work to be able to bring balance to the system as a whole? Well, many times it goes back to that aspect of what's going on in your gut? What are you feeling? How do we take that into consideration? Because we find that when there are stressors, like with separation, it increases intestinal permeability, it decreases the mucin protection that's going on, and decreases our immune system activation. These are important things that we need to consider overall. So for instance, you've heard people talk about heart rate variability biofeedback. When I'm working with patients who have imbalances in their gut, who have cramping, or who have digestive issues going on, using the heart rate variability biofeedback to balance parasympathetic and sympathetic tone is important. That helps motility to occur properly. That's the role of the vagus nerve, the wandering nerve that goes down and increases sympathetic drive. So I've given you this view of how I think about it when patients come in to see me and when I work with other doctors and help to support them in this process. So I'm considering what's the root cause. Now, once I know that, I'm going to go through this 5R process. It's like, okay, well, let's just remove those things, whether they're parasites or foods that the person is sensitive to help bring balance to the system. Let's replace. Let's look for those things that are missing. If there's an acid problem going on, determined by a Heidelberg test or from a betaine hydrochloride challenge, I'm going to give hydrochloric acid. Yes, betaine hydrochloride I'm going to give to help the digestive process. If I see decreases in pancreatic elastase in a stool test that I can get from any laboratory in the United States, I'm going to give them pancreatic enzymes in order to help support that until such time that their villi are working well again and they can produce it on their own. I'm going to support and help to heal the lining of the gut. I'm going to repopulate. And I can use probiotics, but they're an interim measure. Ultimately, I need to work with the diet. Now, 5 years ago, the dogma was what we have as our gut flora at the age of 2, some would say 4 years of age, is our gut flora for the rest of our life. Now, it's actually true as long as we keep eating the same food. Now, if we change our diet, we change the distribution of our gut flora that's going on. It only makes sense. And the diversity of our diet is going to be reflected in the diversity of our gut microbiome. Remove, replace, repopulate, repair. How do I help repair? I talked about L-glutamine already, one of my favorite tools. The use of anti-inflammatory omega-3 fats can be useful as well. Other things including quercetin. In severe cases, giving butyrate as an enema, but that's a rare case that needs to happen. So I'm working to repair the lining of the gut, and I'm working to rebalance those gut feelings that are going on. And again, talking about simple sorts of tools that help to increase parasympathetic tone and increase gastric motility and help to bring balance back to the system overall. So I've talked about this DIGIN approach. And what I'm going to do over the next 2 minutes and 45 seconds is just move through examples of how we do this in practice. You know, you got to treat the underlying cause. So with GERD, which is quite common, we see that it's not really about excess acid, it's about decreased clearance that's going on. So we see with overeating, we see with opening of the gastroesophageal sphincter, we see with problems with hiatal hernia. Each of these things can be problems. So we decrease the meal size from the 12-inch plate to the 8-inch plate. We raise the head of the bed. We work on weight loss so that the weight isn't impinging upon what's going on. But we want to make sure they have adequate stomach acid, interestingly enough. We want to tighten up their lower esophageal sphincter, and we want to improve the motility that's going on. So these foods are going to tighten up or decrease the opening of the lower esophageal sphincter, avoiding these foods. We're going to use medicines. We're going to avoid medicines that actually open up the lower esophageal sphincter. We're going to avoid these medicines. We're going to give symptom relief with DGL and marshmallow. We can use homeopathy, as we heard Daphne talk about yesterday. We can use melatonin, which has actually been demonstrated in clinical trials to decrease GERD. We can also use transit time modulators where we help improve transit time. D-limonene, 1,000 milligrams every other day for 20 days is a great tool. A German herbal product called Iberogast helps increase motility. And heart rate variability helps increase motility. And we avoid the PPIs because as is seen here from gastroenterology, and this is 4.5 years ago, it says PPIs are being used in less than half of the patients who need them. And when you start a PPI, you end up needing to stay on a PPI because as soon as you go off it, you have a rebound GERD that happens. So the patient says, oh, I can't get off of this. It's difficult to get someone off a PPI, but it's really important to do for reasons that I spoke of earlier. With peptic ulcer disease, it's common. 10% of the population, there's inflammatory changes. But it's not just all about H. pylori. That's an aspect of it, and you can use triple therapy or quadruple therapy or mastic gum, but we also need to deal with helping to heal the lining of the gut. We need to work with decreasing meat and dairy and saturated fat. Now for IBS, what I think about is what's going on. I go DIGIN. What's going on with digestion? Do they need digestive enzymes, pancreatic enzymes, and betaine HCl? What do they have issues with intestinal permeability that needs to be supported with glutamine? Do they need fiber, soluble fiber, not insoluble fiber, soluble fiber that's going to help butyrate production in their gut? Do they need probiotics and prebiotics? Do I need to consider antiparasitics or antimicrobial herbs to clean out the system? Right? It's hard to talk about all these aspects in one brief 45-minute talk. But we have tools, including peppermint oil, that have been shown evidence-based to reduce symptoms that relate to IBS. And then with inflammatory bowel disease, common issues of inflammatory bowel disease that relate to where we live, that relate to alterations in the gut flora. And we can work to bring these back into balance as well, including the use of probiotics at 450 billion colony-forming units to maintain remission and 3.6 trillion colony-forming units to induce remission. Now, this is not for you to go and just throw at one of your IBD patients, but to consider and be aware that these are pieces that I need to take into account in the whole picture of this patient. I've got tools to be able, supplements and herbs to be able to support the process. So what I've focused on is around looking at the process of digestion, intestinal permeability, the gut microbiome, inflammation, and the enteric nervous system as a way to try to help bring balance back to the gut. And ultimately, we find in this endoscopy picture that the way to a person's heart is through their gut. And I hope you all find that path. Thank you.